When a surgeon is going to use a new device in a procedure, it's not just about the company and our role in getting them trained. The surgeon and the hospital also have decisions to make about when that surgeon is ready to perform a procedure with this new device. So the very first thing is the surgeon actually already has to have privileges from a hospital to do this given procedure, either open or laparoscopically. So they have an MD, they've gone through their residency training, they're doing the procedure, they already know how to do it. So then the surgeon becomes interested and will come to the company and talk about the training pathway and will commit. And the surgeon will understand that what we're providing is kind of our recommendation is the minimum they should do. As they do more time on the simulator or more hands-on experience, or they watch more videos, or they talk to more surgeons, they will get better trained and they will be more comfortable and more facile. So the surgeon also has that ability to put more time into it and more effort into it. At the end of our training pathway, we recommend that surgeons get proctored for their first few cases. It's actually the hospital's decision in terms of saying whether a surgeon needs to be proctored and for how many cases. We recommend that the surgeon follow their hospital's requirements, but also that they keep in mind that they should be proctored until they feel comfortable operating independently. And then the hospital will decide, okay, we are now going to grant this surgeon privileges or credentials to be able to do this same procedure that they already do, but with this new device. So it's there's multiple people or organizations that are involved. Each kind of has their own separate area that they're responsible for, but it all integrates and they each have to do it in order for the surgeon to get from doing a hysterectomy laparoscopically to doing a hysterectomy on that same type of patient with the Da Vinci system. It is absolutely a commitment from the surgeon to go through the entire training pathway. And so there's a lot of work initially to talk to the surgeon about what that means. You know, what does this training pathway look like and why it's important to commit. And sometimes surgeons, you know, after they go to see a case observation, they see a video and they have that discussion with the salesperson about the investment. They say, you know, I don't have the time, or I don't have the interest, or I don't see the value, so I'm not going to do that. Some surgeons are still interested, and then we'll start the next process, which is some hands-on working with it and taking some tests and seeing how they're doing on the simulator. And at that point, they'll say, you know, I'm not picking this up. This is going to be more difficult. It's going to slow me down. I don't want to do this. Sometimes surgeons get all the way through the pathway, so they've committed to the pathway. They've gotten all the way through it, and then say, this isn't for me. And I think our mission here is to try to give surgeons as much opportunity to make that decision for them as they go along. So at each step, if they say, you know, I'm struggling with this, we can say, well, why are you struggling? What can we do to help you? And we can give them some extra time on the simulator, or some extra time on tissue, or some extra practice. But if they really feel that it's not right for them, then they can certainly bow out and stop at that point, and we encourage them to do that. The last thing that we want is somebody to feel like they have to use the system when they're really not comfortable or really don't want to.